not testing once during the pregnancy, but actually 3 times for the entire pregnancy for syphilis, just because of its devastating effects. We do similar things with the STD screening, just because we do have a higher rate of STDs in our patients. In our neighboring county, Riverside, our residents actually go to Riverside as well. They see a high rate of patients who, there's a higher rate of, actually, you'll have to fact check me on that, but the patients that they see in their hospital, they get much more experience with substance abuse patients. So patients who have opioid dependence. And so those are some of the things that are unique compared to other counties surrounding us.
Awesome. Thank you so much. So I want to go ahead and just thank Dr. Jane Yuen and Rupa Basu for your time and your great presentations. I know I thoroughly enjoyed them, and I know everyone else did. So thank you once again. That was fantastic. I will now be turning over my moderation to Leah, our Financial Officer and Fundraising Chair for the section of Mental Health Disparities.
Hello, good morning, everybody. Hope you can hear me well. Just introduce myself slightly. My name is Leah Abadog, and I am a 4th-year public health major, as well as the treasurer and fundraising chair of Beta Sigma Gamma. I'd also like to introduce our speakers, Dr. Kendra Flores-Carter and Dr. Yuying Tsong. So the format will follow the same as the past sessions. 2 speaker presentations followed by a 10-minute question and answer session. And just to go ahead with the presentations or slight instructions, our first speaker is Dr. Flores-Carter, who is a published author at the California Baptist University, a professor of social work, and a researcher in the social and behavioral sciences field, specifically for women's and child's health. An advocate for social justice and change, she has dedicated her career to bring educational awareness to disparities and equity concerns in the healthcare experiences and various other psychosocial issues affecting marginalized women and children. A former medical social worker for over 10 years, Dr. Flores-Carter worked to provide services to children suffering from trauma related to child abuse and neglect, and women experiencing significant life crises, such as intimate partner violence, substance abuse complications, incarceration, and homelessness and mental illness. So without further ado, I'll now hand the spotlight over to Dr. Flores-Carter and her presentation titled, Culturally Responsive Practice Addressing Mental Health Disparities.
Here we go. Hello, thank you for having me. I appreciate it. There we go. Wait, let me make sure. Okay, am I sharing? Yeah, can you see? Perfect, perfect. Okay. All right, well, thank you. Thank you all for having me today. I really appreciate it, and I've thoroughly enjoyed all of the presentation thus far. So I'm really excited to share a little bit about my work and what I do. So let's get started since I don't have a lot of time here. All right, so objectives is really to talk a little bit about mental health myths, misconception, existing mental health disparities, barriers and stigma, and just talk a little bit about culturally responsive practice as a solution. So what we do know about mental health is that it is a problem experienced by a lot of people. However, there's always myths and misconception. And when it comes to mental health in the minority community, there's always that stigma that relates to how we perceive mental health. So things like mental health is not a problem that's experienced by minorities or by the Black community, right? Some of us have perceptions that, are like that. Therapy is only for people who have severe mental illness, like PTSD or schizophrenia. It's not for people that, are probably stressed out or overwhelmed, right? Which could be depression, but they don't really always know that, right? You can't function if you're mentally ill. These are some of the perceptions that a lot of people from marginalized communities and, minority communities have. Yeah, you can function, not knowing that, no, actually, you can actually function having depression. But people have this preconceived notion that you just can't. Once you're mentally ill, like that's it, end of the world. But it's also another myth in our communities. I'm just going to go over briefly. I know some of the previous presenter talked a little bit about statistics, but what we do know is that there's significant mental health disparities when it comes to people experiencing it. And so according to the National Mental Health Alliance, this was some data that was collected throughout the United States nationally. And so it was done in 2021. And it is estimated that 1 in 5 adults will experience mental illness or have experienced a mental illness. That's about 57.8 million people in the United States. The prevalence for female is 27% of that 58 million are females, 18% are males. Young adults have a high prevalence of experiencing mental illness, 33.7% of this population. What I found really alarming was the highest experience of mental illness was around minority population, which is 34.9% of the US population is experiencing mental illness. So that's huge when it comes to thinking of our marginalized and minority communities, right? Then we have our Native American or American Indian at 26.6%, and then of course our Asian population at 16%. So these are just some, numbers for you to look at and kind of take in. Like, it is definitely a significant problem when 1 in 5 adults is experiencing mental health issues. There's also factors that really significantly contribute to the experience of mental health disparities. At the top of my list is really discrimination and racism, and the way that we as practitioners provide services to people in marginalized communities, right? Minorities, we know, don't always have adequate access to care and are not always given the most appropriate care. The care that's given is often on the poorer end when comparison to, the dominant population. So oftentimes they're getting the short end of the stick if there is access to service, right? They're less likely to have follow-up care. For those who do seek help, they fall between the cracks because they go for help, but then there's less follow-up when it comes to following through to make sure that they're okay, right? That they access these services post maybe discharge from a psychiatric hospitalization, furthering them not getting the help that they really need or sticking to that help, right? Social and environmental factors, poverty and crime exposure. We know these are direct factors that correlates with the experience of mental health. And so what are we doing to really make sure that people that are poor are being assessed in a way that also include the background, their environment, their neighborhood? How is that impacting maybe the mental health that they're experiencing, and how is it impacting the symptoms? Okay. Suicide. We know that suicide crisis is definitely another significant factor with young adults. It is really a public health crisis, and it's increasing in its severity, right? It is actually the second cause of death among US youths, right? To ages 10 to 24. Second leading cause. This is definitely significant, and it calls for more interventions within our school system. There's been over the last 10 years, 56% increase in suicide attempts, right? So it grew from 6.8 to 10.6 per 100,000 people. So it definitely significant, and it's going to probably be a lot more. Like I said, this is statistics from 2021. So imagine post-COVID when we've kind of collected a lot more information around how the numbers will probably go higher. Some barriers and stigmas, and I know I'm going really fast because my time is very limited, so bear with me. So services, oftentimes the services being offered are expensive, right? For mental health. A lot of people can't afford them. So I think consideration should be made to ensure that services that are offered are sometimes free to people that don't have that money. Also thinking through the population, poor, low income population, how do we bring the services to them if they are not able to come and get it. Insurance coverage, logistical barriers. There's people, I'm in San Bernardino County, and so there's people that live in the high desert that don't have access to transportation. So how do we, again, make it more accessible for them? Telehealth, how do we guarantee that they have access to maybe quality internet access so that they're able to access the services, right? That's definitely another important factor. So considering these barriers is really, really important. And also addressing the stigma. We know that there is a significant stigma attached to mental health and really seeking services. So how do we work to not only identify the problem with the individual, but also bringing in that family unit to support the individual who needs to get the help, right? How do we think through processes in bringing that piece in? Because we know, especially for minority communities, having that family support is so key and very important in them seeking services. Oftentimes that will help them to be able to say, you know what, I need help, having that support. Oftentimes we focus significantly only on the individual, but how do we, if we understand that family is important, culture is important, how do we bring that and tie that in as well, right? Educating not only the individual, but the family members. Hey, this is important, right? And addressing that stigma. Talking through culturally responsive practice. And I think this is really key in understanding, hey, how are we screening for mental health, right? What kind of tools and instruments we are using, and is it detecting the symptoms within the diverse population? What we do know is a lot of scales that were created and tested on non-people of color or non-minority. So how do we actually know that they are assessing the right symptoms as it relates to mental health? So that's definitely important. So as you're practicing within the field, how are you ensuring that what you're using is an instrument that's actually measuring the symptoms that's related to, you know, someone who's from a minority background? Is it culturally sensitive, right? And I placed some tools here that, you know, you can consider if you're not doing that. The multiculturally sensitive mental health scale, right, for instance, or the Philadelphia Urban ACEs for trauma. Like things like that is important to make sure that you're looking at not only tools that may have been used before, but they have been tested predominantly on the dominant population and not necessarily minority population. That's important, and that's culturally sensitive practice, right? You're really making sure that the client is the center, and even the instrument that you're using is dedicated and catered to their needs. That's important, right? Who is doing the screening? I know the prior participants talked about training in implicit bias, right? Who is doing the screening? Are those people trained adequately to work with diverse population? Are they trained in implicit bias? And I'm not saying just one-time training, but what ongoing training are you having for your practitioners really to engage in this type of work? You can't take one training and expect to really be able to shift your implicit bias. This is an ongoing learning for you as a clinician working with diverse population. And so another piece to this is, how are you ensuring that while your clinicians and your practitioners are trained in practicing in a culturally sensitive manner, how are you making sure that they are doing that? You've been trained now. Now, how do we get the clients to respond to say, yes, I've noticed the shift. Yes, the clinician is respecting my values. They're asking, they're assessing, they're making sure that I am okay, right? And they're making sure that I feel safe and I feel listened to, and my voice is very important. How are they guaranteeing that, right? That's an important factor. And so, I think that assessing the effectiveness of, the clinicians work with implicit bias and around this, and how the patients or the clients are experiencing this is very, very important, right? And so I think that's one of the pieces that's missing, is that we're training people in implicit bias and unconscious bias, but there's no accountability when it comes to seeing if these training is effective, and if these clinicians are practicing in a culturally sensitive manner, and if it is, producing the outcome that we're expecting it to produce, meaning that the client are now getting quality care, right? And I think you have to tie in both of those, not only the training, but also the experience once the training has been done. And that comes from that client perspective. How were you treated? Was it different, right? So that's another important piece. We understand that when a mental health provider understands the importance of utilizing culture to assist healing, they will give an opportunity for their clients to fully understand not only themselves, but really maximize the access to treatment services and be open to wanting to do that, right? And that's really the goal, is how do we get our clients or patients to want to engage in the treatment for mental health if we have noticed that they need it. It is definitely essential for providers to recognize that culture is fluid, right? And so meaning that people have different lived experiences. And so you cannot assume that every single person is going to have the same experience. You cannot use the same treatment approaches with everyone that you're seeing, because everyone have different lived experiences. And so how do you connect, and how do you make sure that your approach is really being sensitive enough to cater to the needs of your clients, and so that's another important piece. I want to talk to you about a little bit about the practicing from what we call the DPAR framework. And what that is really looking at diversity, equity, inclusion, inclusivity, and power analysis in anti-racist practice. And this is a framework that was founded by Simmons University Director of Social Work Program, Dr. Jacqueline Dyer. And really it's practicing through that lens, through the lens of DEI, and really doing that on a daily basis, creating policies and protocols that mandates practice through a cultural humility lens. Do you have that within your agency? Is this something that you are doing that's embedded to really shift the culture in how things are done within your institution? It's important to make sure that that is also at the forefront, that you're not only doing this on a, lower line work level, but you're really embedding this type of framework within the culture of your organization. So policies, this is procedures, this is practice, that's mandated, right? And so people are learning how to practice through a framework that is culturally sensitive, that really respects that individual and values that individual, as opposed to only getting a training and, saying, I've been trained, I know how to do it. No, how are you practicing this? How are you embedding it into your organization? That's an important piece as well. And I think that's it. I'll stop there for questionings. And thank you very much. This is kind of like how you would contact me. And yeah, I'm open for questions now, because I know I don't have a lot of time. So I have about 10 minutes for questions. So let me end my show here. All right.
Thank you so much for your wonderful presentation, Dr. Flores-Carter. We actually are gonna hold on the question until the end of the presentation. After the next presenter, we will accumulate all the incoming, because there may be more coming in as
absolutely
your presentation. So with that, I will let Leah introduce the next speaker.
Thank you again, Dr. Flores-Carter. Moving on to our next speaker, Dr. Yuying Tsong is the Associate Vice President for Student Success, a psychologist and professor in the Department of Human Services at California State University, Fullerton. And as a mixed method researcher, her research in the clinical areas of interest include sexual and ethnic minority mental health, Asian American body image and disordered eating, immigration and adjustment, transnational families' bicultural adaptation process, and help-seeking attitudes and behaviors. Nationally, Dr. Tsong serves on the American Psychological Association Board of Convention Affairs and is past president and fellows of the Society for the Psychology of Women. She also co-edited the Journal of Women and Therapy special issue on trauma and psychology, well-being of Asian American women, and has an upcoming book entitled Body Image and the Asian Experience, Asians, Asian Americans, and Asian Diasporas Across the Globe. So without further ado, I'll hand over the mic to Dr. Tsong and her presentation titled Mental Health Disparities.
Thank you so much, everyone. Oh, I'm hearing it echo. Is that me? All right. Does everyone hear echo? Yes? Okay. What do we do?
I see that your other mic is off. So I'm not sure why you're still hearing echo. Do you mind like logging out of that? There's two of you in here.
It is? Oh, that's sweet. Okay.
So I can remove the non-new.
There we are. Wait, still echo. I'm gonna come back out. Come back really quick.
Sounds good.
Oh,
There you go.
there we go. I don't know how I locked in twice. I'm sorry. Okay. All right. So I am going to share my screen. All right. Everyone see my screen? Yes. Okay. And if you're open to hop on the open up your screen, I'd love to see your faces, but if not, that's okay too. So I want to talk about mental health disparities today. And thank you so much for Dr. Kendra to really give us an overview and highlight some of the prevalence for population that are traditionally marginalized. So I am going to start with a story. Okay, so I'm going to tell a story of Emily and Nico to kind of, for all of us to start thinking about what is mental health disparity, or what is really disparities, right? That we know the book definitions, and I'll give the book definitions in a little bit, but let's think about people, real people. So Emily and Nico are two kids that I actually know for a very long time. They're the kids of two of my really, really good friends. One is, so both of them have parents with advanced degrees. Emily lives in a district that doesn't have a whole lot of money, and Nico, it lives in a district that has is a very middle upper class neighborhood. So Nico and Emily, they're in the same grade. When they're in both for fourth grade, so you know, the three of us, me and my two friends, we're just kind of talking about their schooling experiences. So for Emily, her school district doesn't have a lot of money, right? And they're in a neighborhood with mostly working class families. And so the district just doesn't have a lot of money, so that in fourth grade, for those of you who know K-12 system, that you have to start taking these state standardized tests, right? And so for Emily, that her experience has been that the school has all the kids will go to the library to take these tests, and the library only has these stations, right? And because all of the kids in the elementary school have to take turns in the library, so you really don't have much choice in terms of what time of the day and which day, when it's turn for your class, you go to the library. The library doesn't have air conditioning. It has a fan, and sometimes the fan works, sometimes it doesn't, right? So for Emily, that was kind of her test taking experiences. For Nico though, right? Nico is in a district that has middle upper class neighborhood, even though all of the state schools doesn't receive a whole lot of state funding, but because of the neighborhood, their PDA was really able to get a lot of donation, right? So for Nico, he didn't have to go to the library to take tests because the PDA was able to get enough money. All of the kids in the school has a Chromebook. So they're already kind of practicing things on the Chromebook that they use every day. They have practice sessions and all of that, right? And because everyone has a Chromebook, they don't have to take turns in the library, right? So what do? The school is very evidence-based, right? So based on evidence, we know that Monday and Friday are not good test-taking days because on Monday, we barely just come up from the weekends, right? Our brain are still recovering from the weekend. And on Friday, we're like so fried. We're really not in the best state to take tests. So Tuesday, Wednesday, and Thursday are the good test-taking days, okay? And also based on research that mint is a smell that alert our cognitive ability, right? So for Nico's school, does not only Nico get to take tests on the Chromebook that he has already have for the entire year, right? He knows exactly how to work the keys. He can take the test on either Tuesday, Wednesday, or Thursday, not right before lunch and not right after lunch either, right? And that all the school is air conditioned, right? So this is like right before the summer break, and that the school has aromatherapy to put out mint mists, right, during test taking time, right? So if you think about that, right, so I asked 3 questions on my screen here, right? So we're talking about 2 real kids in 4th grade taking the state test. We're not even talking about any of the genetic, biological factors in terms of, whether they have any individual factors affecting their academic performances, right? But in terms of just that whole school population, they have very different experiences already, right? So if we think about the outcomes in this particular case, if you were just thinking about their math and English standardized tests outcome, right? We can see that the outcomes probably are going to be different, even if Emily and Nico has the same genetic makeup and has the same family environment background. Just the school itself is already contributing probably different educational outcome. Yes, right, with me? So that's kind of what disparity works, right? Like your socioeconomic status, right? And Dr. Kendra talked a little bit about cultural factor, right? So if we throw into kind of Emily's family environment, have both of the parents being higher education, both of them available to help them. And Nico not only have both parents being highly educated, they also have additional resources, and school has, right, after school programs and extracurriculum, soccer practices. So all of these are kind of the social determinants and factors, right, going into one outcome. So the disparity in the educational outcome is really not just about Emily and Nico. It's not just about their own families, right? It's not just about the school. It really has a lot to do with all of these combined with the district that they're in, right? With the time that they're in. And that's how disparity is really, really complicated, right? So I use that as an educational experiences, because I think if you have kids or kids, these are really real issues, right? So but that is very much parallel, right, to mental health disparity. Because what is mental health disparity? If I can find my mouse to actually move my slide. Oh, there you go. So what are mental health disparities? So mental health disparity are, so many factors contribute to mental health outcomes, right? Including biological. Some of us are more high wired to have a lot more anxiety because we just think about a lot of things. Some of us just have a really lower energy. We tend to get more affected by weathers, right? There are some biological genetic makeup that affects our mental health, right? There are environmental factors. There's psychological, sociological, economical, cultural, contextual, and access to care. So all of these factors contribute to mental health outcome, meaning that how my mental health will be, right? And mental health disparities are when the differences in these factors adversely and consistently affected disadvantaged population, right? So just as in the NIH National Institute of NIMH National Institute of Minority Mental Health and Health Disparity define health disparity as a health difference on the basis of one or more health outcomes that adversely affects disadvantaged population, including Black African American, Hispanic Latinos, American Indians, Alaska Natives, Asian American, Native Hawaiians, and other Pacific Islanders, socioeconomically disadvantaged population, underserved rural population, and sexual and gender minorities. So mental health disparities specifically rise in this population as a result of differences in the incidences, prevalences, or the course of mental health illness, access to healthcare, quality of care, experiences of trauma, adversity, and or inequity of social determinants of health, right? Like I talked about education, economic stability, quality of housing, access to healthcare, all that. So these are the book definitions you're familiar with, or you will be familiar with in your pursuit in public health. But what it comes down to, right? When I try to talk about this with beginning therapists, beginning practitioners, or beginning researchers, is to really think about what are the different things that affect our mental health in a way that's different, right? And in a way that impact certain population more than it does to others, right? And they can be a slew of different things. I'm going to talk about a few of them a little bit, and Dr. Kendra already talked about some of them. So this is kind of the overview of NIMHD, kind of encourage to think about as we think about health outcomes, right? They're the individual level, they're the family organizational level, they're the community level, and they're the population health, right? But and in terms of the dimensions or the factors, there could be biological, behavioral, physiological, right? Physical, or the built-in environment, right? The social cultural environment, and the healthcare system, right? So it's a very comprehensive, if we want to really think about health disparity and mental health disparity, this is a very comprehensive way to think about it, right? And as researchers, right, we oftentimes kind of think about one of the particular thing that I particularly focus on. So for me as a psychologist, and kind of really focusing on sexual and ethnic minoritized population, right? So I focus a little bit more on kind of the behavioral and social cultural environment outcome that I measure. But as I conceptualize the things that impact these outcomes, I have to think about, right, what are the biological disposition that affects the mental health outcome and disparity, right? What are the physical built-in environment, right? Like I talked about for Emily's and Nicole's school, right? If we think about Emily and Nicole, both of them, if both of them are struggling, are starting to have some depressive symptoms, right? The way the outcome is going to be really quite different, because Emily, I know in her school district, like 3 schools share one school psychologist that's funded by PDA of 3 schools, right? Whereas Nicole, not only they have enough resources to have one psychologist just for their school, the PDA has enough money to kind of work with other schools to get additional counselors, right, and support needed. In starting from 1st grade, Nicole's school, not only they have the school psychologists, they also run social groups, right? So they already in 1st grade start to identify kids are kind of struggling socially, and already start to run social support groups, kind of teach them how you make friends, right? How do you speak up in class? And so the built-in environment is absolutely important, right? And for social cultural environment, that's one of the pieces that particularly I have really looked at in my research. So one of the research project that I've done is with Asian and Asian American older adults, and focusing on mental health literacy, which I'll come back to a little bit. But if you think about public health implications, access and literacy is a huge factor, right? Because yes, stigma is really important, but do I even know that the struggles that I have is something that I can actually get help with, right? So one of my study was looking at depression literacy, that do older adults, like whether older adults can recognize depression symptoms and know that this is something that can get help with, right? Because the idea of literacy is that in order for me to even think about accessing care, I need to first recognize this is something that I can get help with, right? So my research project, I give older adults a scenario, like a story that matches their gender. So for Mr. Huang, who's older, he will get a vignette, a story of an older Asian person who's kind of really struggling, not really going out to play checkers anymore, who's really not even calling their kids anymore, and who's just kind of feeling sad, who stopped gardening, and it has been going on for a couple of weeks already, right? So I give them this vignette and ask Mr. Huang, like, what do you think is going on? And so ask my kind of indirect way to try to understand, assess, to measure whether Mr. Huang can recognize depression symptoms. So what do you think? Well, I can't see the chat. So I interview about almost 40, combining both Vietnamese and Chinese Mandarin speaking older adults. How many do you think, well, what's the percentage do you think that of the older adults are able to think what's going on? What do you think the older adults think what's going on? Just quickly, if you don't mind, put it into chat. If you want to guess. What do you think Mr. Huang or other folks like Mr. Huang will say when I give them the story? Like, what's going on with the person in the story? And what can we help with? And so my follow-up question is, so I asked Mr. Huang first, like, what do you think is going on with, Mr. Wang in this story? And then how would you support, how can we support Mr. Wang in the story? So you may or may not be surprised that a lot of the times, both male and female older adults, some of them will say something about, oh, I think he's unhappy, or I think there's something psychological going on. But for the most part, they talked about, oh, it's just him being old, right? This is what happened when you're old. And when we talked about, when I asked the follow-up question, so what do you think we can do, right? A lot of the time they say, so the person, right, who can, the few people who recognize that this is something psychological, they'll say maybe they need to see someone, right? But they oftentimes don't know who Mr. Wang, the person in the story, should go to. A couple of them will say, oh, maybe their doctor, right? But what kind of doctor, they're not sure. A lot of them will talk about, oh, their kids just need to visit more, then they'll be happier, right? Or a lot of the response will be, oh, they just need to exercise. When you go outside and exercise, you'll feel better, right? And some of them will say, they just need to see their friends. Like once they see their friends, they'll feel better, right? So if you think about that, it's no wonder that we see disparities of mental health in a lot of the minoritized population, right? So this is examples of older adults that oftentimes speak a different language, and more than 50% of Asian older adults are born in a different country, right? And that a lot of them have limited English proficiency, right? Meaning that they're not really comfortable speaking in a language that's not their native language. And that in a lot of the Asian languages actually does not have words for depression, for anxiety, for PTSD, right? Words like, oh, there's something wrong with my kidney actually is related to anxiety symptoms. Like I feel like a stuffiness in my chest is oftentimes related to depression symptoms, right? So there are a lot of somaticization way of describing, meaning that describing psychological symptoms in physical terms, right? So that's also another reasons that we see a lot of mental health disparity, because oftentimes folks grow up in these cultures and these languages that really don't see psychological or mental health being separate from our physical health, right? So they oftentimes, like even like in Chinese languages, depression symptoms is all related to the stuffiness of the chest, or I may have digestive issues, right? Or my head is being heavy. So if this is your understanding or your literacy about depression, why would I go see a psychologist? I'm going to go see my primary care, right? So if you think about public health implications and really care being a holistic way of thinking about things, right? That these folks will go to their primary care, but my primary care check my intestine, check my head, check my heart, check my kidney. There's nothing wrong with it, right? So yes, or a visit acupuncture doctor, absolutely, right? So, but if it's really about my depression, all of these things are not going to show up in my primary care, right? And the primary care is going to say there's nothing wrong with you, and then for me, I'm like, oh, that I feel worse, right? Like, why am I feeling this way? So a lot of my work in when I was doing research is really kind of trying to figure out, yes, there's stigma, absolutely, right? And there's communities hesitancy about accessing mental health because there's a lot of negative perceptions about it. But a lot of my work is also kind of trying to figure out what is the literacy piece that we need to decode, right? Because if we continue to code depression, anxiety as only physical, right? And we only treat physical symptoms separate from our mental health, we're going to continue to see these disparity, particularly in the population that really don't see mental health being separate from physical health, right? Does that make sense? Okay, all right. So this is the framework for from the National Institute. And this is another way to kind of, right, see mental health or health in a kind of an ecological way, right? That there's the individual more related factor, right? Like, how am I accepting myself? Do I have access to insurance? How resilient I am, right? Do I have multiple minority stress? Because if I'm female identify, if I have a same-sex partner, right? If I have a disability, I'm gonna have more layers of stress just with me, right? Not to mention my chosen family, my historical ongoing trauma. If you're from a family that are migrating, right? That have migrating stress, that if your family are one of the boat people folks, right? There's a lot of trauma in the migration experiences. If your family have experiences with war during your migration process, all of this is adding to, right, your family and your communities experiences with health and mental health, right? How many Japanese American folks or families don't really talk about internment, right, or in concentration camp experiences because it's very, very painful, right? But if we don't talk about it, the feelings of not belong, right, the feelings of being persecuted for a long time is going to continue to impact us, right? So just really quickly, so mental health in the US, right? And Dr. Kendra really did such a wonderful job kind of giving us some statistics. So just want to show you, this is kind of the really rough population breakdown. So, right, if there's no disparity, we should see the similar distributions of mental health, right, mapping consistently with our population demographic distribution. But the definition of disparity means that it's not mapping, right? That actually they are, this is getting treatment. There are a lot more minoritized folks. There are a lot more racial minoritized population experiencing higher level of PTSD, higher level of depression, higher level of anxiety. So when it's not matching up, that means there's disparity, right? It's infecting certain population more than just based on demographic distribution, right? So very quickly, there's racial disparity in mental health treatment, right? 31% of white children with mental health problem receive mental health services versus 13% of children from diverse racial ethnic background receive mental health services, right? And if we don't reach them when they're kids, right, we're not conducting early intervention and it exacerbates continuously. And this is one of the statistics I cite all the time. Like, if for folks with mental health illness, 48% of white folks will seek and receive mental health services compared to 25% of Asian folks, and compared to 31% of Black folks and 31% of Hispanic Latino folks, right? So this is, but baseline is these all the folks with mental health struggles, but only 22% of Asian actually receive services compared to 48% of folks. If I'm not getting services, I'm not getting better, and my outcome's going to get worse, right? So that's where the disparity is really showing up. I know I'm running out of time, so I'm going to wrap it up. So there are lots of factors. We talked about that already, right? Dr. Kendra already talked about it. I'm just going to highlight that the ease of access is absolutely critical, and mental health literacy is absolutely critical. I did a study with college students asking them why did they go to therapy and why did they stop. The number one reason people stop therapy from college student is, I lost my free access to CAPS. Because when I graduate, because it's really taking a lot of time to go find a provider outside of school. It takes so long to go to an appointment, right? This is before tele appointment, but even that, it just takes a lot of time, right? So be able to have free access and easy access to things is absolutely critical to address disparities. All right, so I am going to wrap it up, and I can't wait to hear your questions or comments.
Thank you so much, Dr. Tsong, and thank you again to both our speakers for the wonderful presentations. I do want to save some time for questions, so starting with Dr. Flores-Carter, there is a question, how do we address the issue of spirituality or cultural issues attached to mental health rather than seeing it as a health issue or disease, just like any other disease?
Yeah, great question. I think it's, again, one of the key components is assessment and assessing if that's a significant part of that client's, coping mechanism. Spirituality is huge for a lot of people of color. For me, instance, as I would like my doctor to ask me about my spirituality when I'm experiencing challenges, because that's a part of who I am. That's a part of my lived experience. So it's very, very important to assess for that, and also work from a strengths perspective to embed that into your approaches in your treatment and your care, because that's going to be probably the way you build good rapport with someone if that's a strength for them. So really, again, assessing if that's a part of how they function, how they focus, and is that a strength that will really help them to get healing? Connecting to faith-based organization. I think, it's very, very important to not only teach our students about just the foundational things, but also how to assess for spirituality. There are spiritual assessments that we can do with our clients. I know that since government and all of that, there's like some barriers there, right? Because when it comes to spirituality and assessing for that, if you work for a government agency, there might be a barrier. Again, that's a systemic problem, because for many of our minority population, religiosity and spirituality is something that's meaningful in their daily lived experience. And if we have a barrier in talking about that and having them engage in things around that, then are we really meeting them where they're at? So, yeah.
Thank you so much. Moving on to a second question. This is for both speakers. Personally, I found it difficult in my own family to kind of address these issues as a Filipino American, but sorry for the background music as well. Both of you discussed the importance of mental health and social support, but what are some ways to confront mental health issues, especially in communities or cultures where these discussions are stigmatized?
I mean, I think it's important to address it. And one of the ways that I personally have even begun, I have 3 children, they're really little, school-age kids. I have really kind of started talking to them about mental health, about emotional health now, because what I'm trying to do is to make my kids feel comfortable with who they are emotionally and mentally, feel comfortable with the spaces that they're in. So one of the ways that we can address this is really connecting to schools. What are schools offering to children that are school age that could go and talk about their emotional health, right? Oftentimes schools, they have interns, they have like school counselors, marriage family therapists, social workers, psychologists that are working in partnership with the schools. Whenever my kids get that form that says, do I want to sign them up? I sign them up for them to go and talk to the school counselor, because even if they don't have an issue, I'm teaching my children from a very, very young age that if something comes up, there's someone that you need to talk to about it, because they're not always going to talk to parents. They're not always going to talk to teachers, but they need an outlet. So I think shifting the culture and shifting the stigma begins now. We have to start when the kids are little, let them know the importance of it, and really engage them in social, emotional, intelligent work from a very young age. So I don't know, Dr. Song.
So yeah, so my one of my research agenda is on help seeking, right? So how do we get people to the support that they need? And my mother, who was a middle school math teacher, she got really depressed after my dad passed away suddenly. And I was so impressed that she actually went to see a psychiatrist that my dad's brother connected her with. She walked in and the person was just saying something that she didn't like. And so I asked her, how did it go? She's like, no, I never want to go back again, right? And I think about her all the time, that it was a huge thing for her to even want to get help. And Dr. Kendra talked about this earlier, right? But when you go and you don't have a connection, or you did not feel good about the experiences that you had, it really further discourage folks to seeking help again, right? So one of my strategy with working with older adults, and also my son, like I've signed him up for everything, right? Because like I'm like, yes, mental health is for continuing growth, right? Like vitamin versus antibiotics, right? But for him, he still hates asking for help for anything, right? So my strategy, especially with my modern older adults, is really exactly that Dr. Kendra said. Support is support, right? If they have resistance to mental health right now, let me make sure my mom has her sibling around. Let me make sure she's going to classes that she enjoys, right? Let me make sure that she is talking to her students from the past, right? That social support, just continually engaging with others, I'm going to start with that, right? And then in the meanwhile, let's figure it out. Can we find a provider who is culturally responsive, right? Who can meet their needs? But I'm all for any support that can engage folks and keep their spirits up. It's absolutely important. And I will speak in any language or for anything, any form, gardening, right? Music, playing, anything, as long as it's feeding the soul of the person, I think it's wonderful.
Thank you so much. I think I have time for just one more question, but for both speakers again. We have heard how there are trainings in place to reduce mental health disparities. And as a recipient of mental health care, how can we best advocate for ourselves for optimal care?
I think it's speaking up, know your rights. Wherever you go, you have rights in public institution where you go. They have this thing called patient's rights, client rights, and they should have that. Another thing is researching your therapist, right? Not all therapists are good therapists, right? And so researching and finding out the type of work that they've been doing, the modalities that they use, right? If you were looking for maybe a Christ-centered individual, there's a lot of Christ-centered therapists out there. You might not want to go to a secular therapist. You might want someone who is doing that work, right? And who can engage you in the type of treatment that you're seeking, right? So do your research, and also making sure that you are comfortable, where you want to engage, and that it's a safe space for you, right? So those are the things that's important, that you're valued. I think oftentimes we go into spaces where we don't feel valued. As a woman of color, highly educated, I often go into spaces where I'm judged immediately as I walk in the front door, right? Oh, here comes this Black welfare mom, which I am completely not. But because of what I look like, that's the assumption that people make about me. And the moment that I go in and I see your attitude is like that, I'm not coming back again, even if I need help. And so again, this is where the accountability piece comes in. You're getting these trainings to really have cultural humility, right? How are we making sure that our clients, I'm having an echo, that how are we making sure that the clients that's receiving our services are comfortable, right? How are we create focus groups? Hey, I'm going to have a focus group with 12 of my patients to see if, my work is effective. Do that. Do that in spaces that could help enhance care, right? It's one of the things that I do. So if you want to do a focus group and you want to find out, call me. I can help you figure that out, okay? Is the implicit bias working? Are your patients okay? Do they feel like what you're doing is helpful, right? And so that's important.
I think for the for as recipients of mental health services, right? Was that that I often encourage students and just students in my class or students that I engage with in different places, and also just professionals to think about when you date a person, when you're trying to find a partner or a spouse, you don't just marry the first person that you meet, right? Marry the person that you go on the Tinder or whatever date with. Like, you gotta get to know the person. You gotta try you gotta just meet different people. If you're lucky, you meet your soulmate like on the first date, power to you. But for most people, like, it's a process to finding that fit, right? It's absolutely the same thing of finding a therapist that's right for you, right? A therapist can be fantastic for both. It may not fit for what I need, right? So one of the things just give it a try, meet people, because it's important that you feel like this is a person who listens to you, who understands you, who wants to understand you, who may not have the same background, but you can feel that, right? And I think the most important piece that I want to really encourage you all to think about is that when there's not a fit, let's try not to put the blame on ourselves. Like, I'm not being a bad patient for not fitting this therapist, right? It's just that there's not a fit between this person and that person, right? Just like a state doesn't work out, it's not always us, right? It's just like these two people don't work out. So I think that perspective is really important, right? Because a person, right? So just let's try. It's a vitamin. We're just gonna keep trying until you find the one, because they will be one. I think consistently across the APA, the training really, I think compared to when I went to school, the level of attention on culturally responsive care is so much more in so many more programs. It can still be a lot better, but I think the number of therapists that out there who are really wanted to and committed to caring for clients of different background is way more than it has before. So I just want to encourage all of you to keep trying, yeah, and not blame yourself, not feel guilty for not finding the right one right away. It's not you.
Thank you so much. I actually didn't really think about therapy in that way, but just wanted to wrap up and say thank you to both our speakers, Dr. Flores-Carter and Dr. Tsong. And now I will hand the mic over to Dr. Park.
Thank you so much.